Good afternoon, everyone, and thank you for joining this webinar. You're very welcome. My name is Amy Casey, and I'm the Communication Manager for Endo-ERN, and it's my pleasure to welcome you today, and also to thank our presenters who you will meet shortly. We really appreciate them taking the time out of their busy schedule to make these presentations, which I know you all find so informative. Today, we have MTG4, and you'll find out more about them shortly. Right now, I'd like to cover the housekeeping. We will have the presentations for the next 45 minutes, and then at the end, we will take the questions. You can answer questions by, you can ask questions by putting them into the chat. And also at the end, you could raise your hand and I will unmute you so you can ask your questions. So without further ado, I'm going to hand it over to our EPAG from MTG4, Petra Bruegmann. Thank you, Petra. The floor is yours.
Thanks, Amy, for the nice introduction, and welcome everybody on the Zoom and on the meeting. On behalf of Endo-ERN and the MTG4, I extend a warm welcome to you. Thank you for taking the time to listen to Professor Frederic Castinetti, Dr. Antje Redlich, and Joe Gray today. The focus of today's webinar will be on MEN2. Dr. Antje Redlich from Magdeburg, Germany, will begin by discussing the distinctive features of MEN2 in children. This will be followed by a presentation by Professor Castinetti from Marseille on genotype phenotype correlation in MEN2. Both Frederic Castinetti and Antje Redlich are co-chairs in MTG4 in the Endo-ERN. The third speaker of this webinar also belong to this working group until Brexit. Joe Gray will address the patient perspective on this disease. Well, let's start with the pediatric insights presented by Antje Redlich. She's acting head of the pediatric clinic at the University Hospital in Magdeburg and study director of the MET registry over there. This is a registry for children with endocrine tumors. Dear Antje, thank you very much for your time, and the floor is yours. Thank you.
Thanks a lot, Petra, for this kind introduction. I want to start with the pediatric aspects of MEN type 2. First of all, I want to show how pediatric oncology is organized in Germany as well as in Europe. All children with cancer are treated in national clinical trials or registries. There is one study center for each entity who collects all the data of all the national pediatric cases, gives recommendations regarding diagnostics, therapy and follow-up, offers central review, for instance, for histology or imaging, offers molecular analysis in cases with dismal prognosis, and if there are some issues in the treating pediatric oncological center, there is always a virtual tumor board to give answer to the question in treating the children. That has led to an improvement in overall survival over the past decades. Approximately 80% of all children with cancer are cured, actually permanently. In the MET registry in Germany, there are included thyroid carcinomas, adrenocortical tumors, pheochromocytomas and paragangliomas, as well as neuroendocrine tumors of the gastrointestinal tract in children. And we have approximately 80 to 90 cases per year of these rare tumors in children each year in Germany. On the European level, we are connected, for instance, in the expert group, the European Cooperative Study Group for Pediatric Rare Tumors, as well as in Endo-ERN and PETCAN. We have a common database. We give common recommendations. We have clinical trials. For instance, we are planning a trial for ACC, adrenocortical carcinomas in children, and we have a clinical patient management system. I want to present today the children with medullary thyroid carcinomas in children, because the vast majority of these children are affected by MEN type 2. We have registered in more than 20 years in Germany 57 patients with MTC, and as you can see on the inner circle on the right side, we have half of them MEN 2A patients, half of them MEN 2B patients, and it's very rare that there is no red mutation in 2 cases, and in 1 case we have the red mutation only found in the tumor and not in the germline. In MEN 2B patients, the MTC is more aggressive, more advanced, and has a poorer prognosis, and unfortunately most of the patients harbor de novo mutation. That means that there is no positive family history to detect these children. On the right side you can see the patient report over the years. There is a peak in the year 2000 that was due to the availability of the red screening in the relatives of index patients, because it was clear that a red mutation leads to MEN type 2, and that's why it is an artificial peak over the years. And this slide should show you that it's not easy to exclude an MTC in children harboring MEN type 2A or 2B. In MEN 2A patients in our study cohort, no tumor was seen in over half of the children affected. In MEN 2B, there were uncertain ultrasound reports in more than half of the patients. So you have to be aware that in red mutated children, there can be a tumor even if it's not seen in imaging. The same can be said with preoperative calcitonin in MEN 2A patients. We have MTCs even with normal calcitonin before surgery. In MEN 2B, it was always and to a higher degree elevated before surgery. The outcome of MTC in children is better without metastasis. On the left side, you see the impact of lymph node metastasis on the overall survival. On the right side, the impact of distant metastasis. If they are present, you have approximately 40% long-time overall survival. MEN 2B, the overall survival is slightly poorer than when compared with the MEN 2A patients. And if you can detect the children via family history or via signs and symptoms associated with MEN 2B, and you can perform a prophylactic thyroidectomy, the overall survival in our cohort was 100%. That's why we made a retrospective analysis of our MEN 2B patients, because they have other signs, symptoms, stigmata to detect these children before they develop a metastatic MTC and die from this cancer. In our cohort, we found very often in bold there are the symptoms which were very often. You find oral neuros of the tongue, the lips, enlarged nodular lips, a maphanoid habitus, chronic constipation since early infancy in 2/3 of the patient. Tearless crying I've made in bold because Bruegmann et al. Described it as the ideal premonitory symptom, but in our cohort it was only present in 16%, maybe due to another approach, because Bruegmann et al. They asked the parents and we took our data from the medical records. And we were the first study group who reported short stature in half of the patients with MEN2B. And we published that, and that are the growth charts, female patients and male patients. And as you can see, the short stature is present since birth. So you have to be aware if there is chronic constipation and a short stature, think of MEN2B, because you can save the life of these children. Other study groups proved this as right and published this finding as well. This slide shows that if MEN2B patients are diagnosed via signs of MEN2B, the overall survival was 100% compared to a decrease to 50% if they are diagnosed via symptoms of MTC. And in this publication, we tried to figure out how the symptoms are preceding MTC symptoms. In black, you see the line, the MTC symptom in the course of the first years of life when they occurred. And you see on the left side, for instance, chronic constipation is present in 40% of the children in the first years. On the right side, you see our findings of ophthalmologic symptoms. They occur later in life after MTC symptoms, and in our opinion, they are not ideal to detect these children. We figured out this for oral symptoms as well, and the oral neuromas are present a little bit later in life to a higher degree. Musculoskeletal symptoms are present, short stature, Marfanoid habitus, and they can precede symptoms of MTC. And why do I only talk about MTC? In our study cohort, pheochromocytomas and paragangliomas are collected as well. But as you can see on the slide, it's not a pediatric manifestation of MEN2. We have only one patient with MEN2B. In the majority of pediatric patients, you find von Hippel-Lindau, SDH mutations, sporadic Cation, or Pachak-Zhuang syndrome. So I don't talk about this manifestation because it occurs in early adulthood normally. So what are my take-home messages? An MTC in children, the vast majority will or has a red mutation as a cause of the MTC. Think of MEN2B if chronic constipation is present since early infancy, short stature, tearless crying, and so on, to save these children of dying from metastatic MTC. And pheochromocytoma in children is rarely a manifestation of MEN2. So that's from me.
Thank you, Antje, for your very interesting insight. And I think we should discuss questions after all those speakers gleich. I would like now to welcome Frederic Castinetti from the Marseille University in France. His work has been focused on the MEN type 2. He has co-authored several national and international guidelines on the management of pituitary and adrenal diseases. Currently, he takes part in the international guidelines on the diagnosis and management of MEN type 1. 1 year ago, he organized the World MEN meeting in Marseille. Dear Frederic, great to have you here. I now hand over to you.
Thank you so much for this kind introduction. So I assume you see my screen, right? Okay, perfect. So I'm gonna briefly discuss genotype-phenotype correlations and phenotypic variability in MEN2. And just as a reminder, Yeah, so as Antje told you before, there are two main entities in MEN2, MEN2A and MEN2B. And both of them actually include medullary cancer in roughly 100% of cases and pheochromocytoma, let's say in 50% cases. You see in this slide there are other diseases that can be included in these two different entities, such as primary hyperparathyroidism in MEN2A in roughly 20% of cases, or Marfanoid habitus, for instance, in MEN2B, as shown just before. So basically, what has long been considered for medullary cancer is that the main RET variant, and you have these here. I don't know if you see the pointer, but you have several variants of RET that can lead to MEN2A. What that you might have for one mutation presumed the risk of aggressiveness in terms of medullary cancer. And then depending on that, you would go to a therapeutic procedure or monitoring. And basically, depending on the risk of this RET variant, you would go to total thyroidectomy in the first year of life. This is for MEN2B and the RET 918 codon variant. You could have a total thyroidectomy before the age of 5 years of age for high risk. So this is mainly 634 codon variant. And then for all the other variants that are shown here, you would be in a moderate risk. And for this moderate risk, you could either decide to go for total thyroidectomy when calcitonin increases, or just to go for monitoring and then check whether you want or not to go to thyroidectomy. This is the case for children. For adults, basically, you think about the rate of the level of calcitonin. Depending on that, you would go for thyroidectomy or not. So this was the original idea, that the RET variant would define the aggressiveness, and depending on literature, saying that, for instance, in the highest risk, you could have lymph nodes metastasis at the age of 1, you would go for a given age for thyroidectomy. And this is actually questioned by this manuscript that was published by the MD Anderson in 2017. So there was the first manuscript that they tried to determine whether this RET variants were actually leading to a higher risk of aggressiveness or just to an earlier onset of the disease. And what they did here on the left side, that they took into account the age at diagnosis rather than, let's say, the physiological age, and they determined whether the survival was different between patients with variants of moderate risk and patients with variants of high risk. And what they showed was that basically the natural history was quite the same between these different variants. The only difference actually was the age at which the medullary cancer was appearing. So in other words, when you had a high-risk variant, you would have a medullary cancer that would appear earlier than if you had a moderate risk. But if you don't take into account this first age at diagnosis, then you would have exactly the same natural history. And it was basically confirmed by two other studies coming from Germany, one in 2019 and the other in 2020 or 21, based on 300 and 160 patients. And in these two studies, they tried to determine whether the rates of lymph node metastasis and systemic metastasis were different between high risk and moderate risk. And what they showed was that, again, the natural history was quite the same. So now we're trying to analyze this a little bit differently, like for instance with a French multicentric study in France, and we're trying to confirm that actually the natural history is roughly the same. It doesn't question the age at thyroidectomy, which should still be the same because the age at first diagnosis of medullary carcinoma or medullary thyroid carcinoma onset is earlier for high than for moderate, but this clearly shows that probably it doesn't emphasize the risk of aggressiveness. Final point is that for higher risk, so let's say M918T RET variant that is seen in MEN2B, the story is completely different. And for these patients specifically, they have a very high risk of presenting with something that is very aggressive. So this is the main idea in terms of genotype-phenotype correlation, but actually there are still unexpected phenotypes despite this basic genotype, and this is coming from our center. So what I just wanted to show you here, let's see that we're gonna check the blue dots. Blue dots is for 634. As I said before, 634 would lead to an early thyroidectomy before the age of 5. So what happens if you don't do this early thyroidectomy before the age of 5? So these patients, here you have the age at surgery, and if you have a last level of calcitonin, what you see is that there are a majority of patients operated after the age of 5 who would have remnants in terms of thyroid cancer and would have increased calcitonin levels. But you see that there are some other patients who were operated after the age of 5 who actually would end up with a normal calcitonin, the majority of them with only one surgery. It means that among this group of patients with 634, there are some who seem to be protected from an aggressive phenotype and who would actually be in remission despite the fact that they would be operated after the age of 5. This was also seen in MEN2B, and this is a large international multicentric study that we performed in 2019. And so in MEN2B, if you take into account all the patients that were operated after the age of 1, which is the recommended age for thyroidectomy, you see that in this series, we had 15% of patients who were in biochemical and structural remission with only one surgery, despite the fact that they had been treated far after 1 year old. So it means there are probably some other factors that are protective in this patient, and we don't know them perfectly well. So as a summary of this first part, in MEN2 medullary cancer, the correlations between genotype and phenotype may be altered because of factors that are not yet known up to now. Let's talk about the second disease, which is pheochromocytoma. So again, the idea is that you have one mutation with one age of onset, and the risk that is going to be higher for bilateral pheochromocytoma, for instance, with some variants. So this is coming from guidelines that were published in 2012, and you have here the mean age at diagnosis of pheochromocytoma depending on the variant. And you see that, for instance, for red variants at high risk for MTC, see that the first age at pheochromocytoma was lower than for other variants, for instance. And it's quite the same for MEN2B. The first age was 12 years. What we had shown in two different studies was published in 2014 and 2019. So here you have a percent of patients with pheochromocytoma and the age for unilateral and bilateral pheochromocytoma. In blue, you have 634 codon. In red, you have 919, and here you have the exon 10, so moderate risk. And you see that basically, as shown before, there is a wide variability between both status. So if you have high or higher risk in terms of red variants, you have a higher risk of presenting with pheochromocytoma, either unilateral. Mean age was 35 here to have 50% of patients with pheo, and let's say 45 for bilateral pheochromocytoma. For exon 10, to reach 50% of patients with pheochromocytoma, you would have to wait till you have a mean age of 70 years old for unilateral pheochromocytoma. So for pheo, you see that red variants define the age at which you present pheochromocytoma, but we'll see on the following slide that there are other factors that might modify this. Just a word on MEN2B, because Antje already presented you this. For MEN2B, you know that there are some extra endocrine symptoms that are listed here of diseases such as ganglionomatosis, malphanoid appearance, digestive disorders. But you see that the rate is inconstant in the patients. We don't really understand why some patients would present these and others would not, but probably there are some variability, might be in terms of genetic background that would protect some patients, or in contrast, that would worsen the phenotype. So what might be these factors? It could be the addition of somatic variants, it could be environmental factors, it could be genetic factors, or it could be, for instance, a parental effect with epigenetic alteration. So I'm just gonna show you this briefly, one slide per each point. So how about the role of somatic mutation? So the idea here is to say that for a given patient with MEN2 and the germline Rett variant, you could have a different natural history, for instance, for MTC here, that is due to an additional somatic event. So this is a case that we reported recently, a woman with a Rett variant supposedly leading to a moderate risk of aggressive medullary carcinoma, and who actually presented with a rapid worsening of the disease with metastases. And when we analyzed this from a somatic viewpoint, we identified an additional somatic event, the Rett M919T variant. And you probably know that this variant is involved in sporadic MTC with somatic variant, leading to more aggressive medullary carcinoma. So it's very rare, only 5 or 10 cases reported in the literature about that, but this might modify the natural history that is due to this germline variant. The second point would be environmental factors. So this is a study that we published in 2017, a multicentric study. And for this, what we tried to analyze was if there was a difference in terms of penetrance of bilateral pheochromocytoma, depending on the geographical area of origin. So we had patients who were from Western Europe, Southern Europe, Central Europe, and others that were from South America. And these patients, they all had the same way of being monitored in terms of diagnosing pheochromocytoma in all these centers, which were expert centers. And what we showed was that if you were coming from Europe, you had a 50% risk of presenting with bilateral pheochromocytoma by age 45, compared to patients from South America who would have a 50% risk by age 60, 65. So this would suggest that people from South America might have protective factors, and we hypothesized that it could be due to environmental factors, which would be different in South America compared to Europe. How about the amino acid substitution? So we talked about the codon. So for instance, 634 would lead to high risk. And as I said before, it would lead to an earlier appearance of medullary carcinoma. In this study was published in 2023, Chinese study. They analyzed 186 patients and they compared patients with a C634R, 92 patients, with other amino acid substitutions. They had a median follow-up of 11 years. And what you see here is overall survival, disease-specific survival, and distant metastasis-free in patients with a 634R compared to the others. And you see that patients with 634R had a more aggressive phenotype compared to the others with a more aggressive medullary carcinoma, as if the change in amino acid will lead to a different natural history. Another point that I wanted to show you is the potential role of non-pathogenic Rett variants, so single nucleotide polymorphisms. And this was for pheochromocytoma. It was shown in 2 different studies, one from South America and the other one from France, multicentric studies. And you have here the penetrance of pheochromocytoma, so here the age, depending on whether patients had none of these single nucleotide polymorphisms, one single nucleotide polymorphisms or 2. And what you see here is that basically patients with 2 single nucleotide polymorphisms, so meaning non-pathogenic variants, actually presented a higher risk of presenting with pheochromocytoma compared to the others. Final point is discussed in a manuscript that was published in 2022 in Germany. They analyzed whether the transmission coming from the father or the mother would lead to different penetrance in terms of pheochromocytoma and the different rate of metastasis, node metastasis in terms of medullary carcinoma. What they suggested, here you have the cumulative rate of metastasis and the cumulative rate of pheo, was that the phenotype seemed to be complete earlier when the transmission was given by the father compared to the mother. Just as a potential bias, when we analyzed the genotypes of these patients, you see that actually there was a little bit more high risk in the affected father group compared to the affected mother. It probably doesn't explain all these results, but it might at least explain a part of difference between these two groups. So as a summary, compared with MEN1, MEN2 is characterized by a stronger genotype-phenotype correlation, but there is phenotypic heterogeneity in the patients, well, depending on the variant that they have, but even within the same families. And the penetrance of the different compounds of MEN2 can be highly variable. The variant of Rett determines the age at first diagnostic of medullary carcinoma and the penetrance of pheochromocytoma as a whole, but there is an individual variability, and we don't really have major factors to explain this. So among these factors, that might be, as I showed you, some genetic factors, but this mainly emphasizes the need for international registries that can be done under the auspices, for instance, of the Endo-ERN, to try to better understand the mechanisms of MEN2. And that's it. Thank you for your attention.
Thank you very much, Frederic. That's it. What we patient always say: registries, data. This is a must, and nowadays anyway. So thank you very much for this insight. And coming to the patients, this brings us to the third part of the webinar, the patient perspective. As an affected MEN2 patient and CEO of the well-networked British patient organization AMENT, she has been in contact with numerous main MEN patients for many, many years. However, she's also very effective in representing the interest of patients in the medical environment. She recently accepted an invitation to Korea, where she was the first patient to present MEN issues at the Korean Symposium in the Asian region. In 2016, we jointly launched the European MEN Alliance, EMINA. Dear Joe, we are looking forward to your presentation. The floor is yours. Thanks.
Thanks very much, Petra. Good to see you all. Nice to be back. Thank you to Endo-ERN for inviting me back. That's lovely. Thank you. Can you see my slides? Because I can't. Okay. I'm not quite sure how to advance them, but we'll see.
Nice. Everything is fine.
You can use the right arrow if you like, Joe.
Is that going to work? I'm not going to be able to see which slide I'm on. That's the only problem. It's not working like it did yesterday. Sorry.
If you like, I can project from here, and then you can ask me to move them on if you'd prefer.
Yeah, is there something I've pressed? I'm not sure. Yeah, whichever works, Amy, but I can't see my slides.
We can see your slide, but you have yet to advance.
Okay, is that just... No. I can't see any way of advancing, Amy. I'm trying my...
Let me project from here then, just a moment.
It worked so beautifully yesterday, didn't it?
Yes. Now, do you see the slides?
I do, yes. Are they in full screen mode? Can everyone see them?
Is that okay for everyone? No, they're... Can we see them in full? Joe, can you see them in full?
I can see a small one with the next slide.
Okay, let's do this then. How's that?
That's full. Is everyone all right with that?
Yeah.
Can you see?
Sorry, that's you know, I've got historical problems with technology, but it worked beautifully yesterday. I apologise. Anyway, thank you for having me.
We have a full screen. Is that correct?
That's perfect. Thank you.
Great. Yeah. You tell me when to advance.
Oh, okay. Right. So let's go. Next one, please. Thanks, Amy. Oh, I might have control now. Thank you. Okay, so Petra mentioned I am a patient. I have a 634 RET mutation and all the joys that go with that. CEO of Amend and a board member, as Petra mentioned, of EMENA, the European MEN Alliance. And there are other sort of hats that I wear as well there for the European Society for Endocrinology, ENETS, the MEN1 Task Force, a new project for adrenal tumours in the UK, and I'm also on the the International Neuroendocrine Cancer Alliance. So next slide, please. Amend is a UK-based patient group, but all our resources are free for everyone to access, so great for any English-speaking patients. And we provide everything for free, including information for children as well, and some research funding sometimes as well. Next slide, please. And EMENA is the umbrella organisation. So there are a number of European patient groups that deal with MEN syndromes that are members of EMENA, and we try to work collaboratively as an organisation to improve things for MEN patients throughout Europe. Next slide, please. And again, sorry. So when we talk about the patient, we go back one. When we talk about the patient journey, if you like, we frequently reference a roller coaster, a bit like this one, lots of twists and turns, ups and downs, etc. But if we go to the next slide, what's often forgotten, I think sometimes, is that to get on the roller coaster, you do have to stand in a queue for a very long time. And in actual fact, this sort of represents or typifies an example of what happens with patients, and particularly index case patients, but not solely index case patients, waiting for a diagnosis. Next slide, please. So just an example, my own is the easiest to give. So I had 4 years of varied symptoms, and you can see from the list, and probably any endocrinologist on the call here would be able to identify what was wrong with me straight away. But unfortunately, I couldn't get past my GP, was labelled an anxious new mother and postnatally depressed, and ended up in a private psychiatric hospital where I was diagnosed within just a few days. So I was very, very lucky. Next slide, please. And this was the culprit. You can see massive BP spikes there, which was when I could keep the cuff on, and a very large 16 by 12 centimetre pheochromocytoma, who I nicknamed Tyson after the boxer. So next slide, please. So EMENA has been doing work, and it's working still. The last survey that EMENA did was published in 2021. It was about quality of care in Europe. It was gleaned some interesting facts, really. So you can see from that, this includes MEN1, this data, but you can see there that the time to diagnosis is still pretty bad. I don't have there exactly when these people were diagnosed, but you know, these should be a bit lower, unfortunately, but this is what we're still seeing at the moment. Next slide, please. And actually, we run a psychological counselling service at Amend. It's a very expensive but very nice service to have. And year on year, we see the same problems for the people who are actually using the service. It's only a small number of patients, but it's always dealing with diagnosis, actually receiving the diagnosis, dealing with it, coping with it. And so much so that we've developed literature about how patients can cope with this as well. Next slide, please. So once a patient's got their diagnosis, they can get on the roller coaster and start their up and down, side to side journey. Next slide, please. And again, sorry. Okay, so I was diagnosed in 2000. I had my first adrenalectomy. I was shown to have MTC and MEN2A that same year as well, and underwent a total thyroidectomy for medullary thyroid cancer. My children, both my children and my mother, were tested in 2001, and my mother went straight for bilateral adrenalectomies. She'd had thyroid removed 10 years previously, but they didn't test for MTC, so they diagnosed her with papillary, and then 10 years later diagnosed her with both papillary and medullary thyroid cancer. So in 2002, because my son had proved to have MEN2A, he underwent prophylactic thyroidectomy, and I include a picture there of him with his throat cut, with his plasters on, because children make far less fuss of the whole process than adults do, that's for sure. So he was very happy playing after his thyroidectomy. Next click, please. 2003, I had a few symptoms, very mild, but I knew what they were, and I went for a second adrenalectomy and am now adrenally insufficient. Next click. And in 2007, I had very, very painful shoulder, so we went for several scans, nuclear beds, etc., and decided that there was an MTC metastasis in my shoulder, so I had that replaced. Next click. And now I am pretty stable. I just go for my annual appointment, have some regular screening, medicine dose adjustments, etc. Next click. But last year we had news from my son that a scan had shown a small adrenal lesion at the age of 24. So he did reasonably well there. So next slide, please. So again, back to the Eminent Quality of Care survey, there was some really good news actually, and we like to think maybe this is because a lot of the people who completed the survey and responded were actually members of patient groups. And I'm pretty sure that they'll have gained some information and support from those groups, which has meant that they've got to the right centre for their care. So their perception of their quality of care was either good or excellent, really, for the majority of patients, which is wonderful. Obviously, variations between the different types of MEN, but overall, you can see there they felt listened to by their doctor, and they had enough time to talk to them, involved about decisions about their care. They felt their medical team was knowledgeable about MEN, and the big one for me, massive one for me, is that they felt they could trust their medical team. And if you've had a long route to diagnosis, a difficult route to diagnosis, it is very difficult to start to trust health professionals. And to be honest, once you're in a centre of expertise, I think you can feel it as well, and you can feel that trust. So it's very important. Next slide, please. We also asked whether people had access to a specialist nurse. I mean, for many of us, that kind of typifies a centre of expertise, is that there is access to a specialist nurse, and it has been shown that actually patients do better when this is the case. And actually, there was a surprising number of people who either said no or they didn't know. And definitely a bit of shame and something to work on, really. And then we also asked, is an expert MDT involved in your care? And the majority there said yes, which is great. But again, there's still a proportion who don't know. And I think it's just something that maybe clinicians need to talk about and actually say, yes, we have these things. Certainly help with the level of trust and engagement from patients, definitely. Next slide, please. Can I do it? Oh, no. And as has already been mentioned about MEN2B, there are other non-endocrine issues which actually require not just an endocrine MDT, but more of an interdisciplinary MDT for these patients, because otherwise they might end up going to all sorts of different places, multiple appointments, and it has a massive impact on their lives, definitely. So next slide, please. So we had an update recently. This is our own data from the people who use our counselling service at Amend, and this was our 2023 report. The former one that I showed earlier was 2021. about the same number of people using it. But here you can see the picture has completely changed, and it's quite dramatic. Dealing with diagnosis is still up there, but actually managing treatment has increased dramatically, as has managing symptoms and fears for the future. So there's something going on here. Next slide, please. And actually, when we looked at the sort of presenting themes, emerging themes from people, we have never seen anger and fear and frustration on this chart before, and it came as a real shock to us. So we asked our counsellors what could possibly be the cause of this. Next slide, please. And this is what they said. And I suspect maybe it's a very UK problem at the moment, but maybe you can relate from other countries. I can see Petra's nodding her head there. There was increased anxiety about our National Health Service post-COVID, the impact of COVID, the backlog, and whether treatment or monitoring would actually be on time or reliable. People have been very anxious about this, definitely. We've had strikes. Our doctors have been on strike from time to time, so people were worried about that. But also rail. So our trains have been on strike regularly as well. And that just compounds the anxiety, because if you've got to get to a centre of expertise that's 50 miles away, it just makes life really, really difficult and stressful as well. We've had a spate of Whipple's procedures recently as well, so that's featured in the anxieties as well, and a lack of disease awareness in other health professionals, so not endocrinology, but maybe when you're an inpatient and perhaps there's a what we call a bank nurse, so a temporary nurse who's filling in and doesn't know anything about it. And also, actually, very interestingly, conservative treatment rather than getting rid of tumours. So watch and wait, as it seems to be termed now, is actually causing quite a lot of consternation in patients. And I think some time probably needs to be spent on really making the case for watch and wait and really explaining why this is the best course of action for a particular patient. Next slide, please. So very, very recently, our counselling service provider, who's called Rare Minds, have just published a report, and they looked at 188 rare conditions, and includes a lot of MEN syndromes in there as well, not exclusively though. 695 respondents, 75% of which were patients. 85% of everyone who responded felt that having or caring for someone with a rare condition had negatively impacted their mental health or emotional well-being. And 75% had never had a healthcare professional offer support or signpost them to support for their mental health. And 96% felt that the mental health support should be delivered by someone with an understanding of the impacts of rare conditions. And there you can see a quote and also a link to the report, which I think is also attached in the chat, possibly. So, I mean, this all sort of compounds the trying to live with a disease for the rest of your life, however long or short that may be, has a really profound negative impact on mental health for many patients, and that really shouldn't be underestimated. Next slide, please. So summary, negative impacts on patients, time to and dealing with diagnosis, it's always a problem. Next click, sorry. Managing symptoms, concerns about inheritance in the future. We have a lot of people who are worried about children inheriting or who have inherited the condition. It causes a huge amount of guilt in the parent. And so we do a lot of work with people about that. Managing treatments was the greatest issue in 2023, but is probably compounded by current and recent environmental and economic events. And although most MEN patients in Europe were happy with the quality of care, we'll wait to see what changes occur because EMONA is doing a new survey this year on unmet needs, which will make giving presentations about unmet needs like this one much, much easier, because we'll have some actual proper data rather than gathering it from lots of different sources. Next click, please. I think there's another one. So, and general practitioners, family doctors are not knowledgeable about MEN syndromes, and this impacts the diagnosis, time to diagnosis, and also routine care outside the specialist centre. And we're not saying general practitioners should be knowledgeable about MEN syndromes, but although I think it would be helpful if they know there is a patient or two in their practice, then it's good to read up, I guess. But referring on or looking out for red flags, I think this is something that we're always working on. So we will try and improve things over the years. Next slide. I think there's one. Click, click, click. Thanks. Patients need to be routinely cared for. Accredited centres of expertise always goes without saying, but it has to be repeated. Access to emotional support throughout the patient journey really, really would be such a great thing to have. And I know in the UK, our budget for psychological services has been slashed to almost nothing on the National Health Service, but patient groups shouldn't be the ones to be providing this. Unfortunately, we do because we can for now, but it's very expensive. And the endocrine community and societies really need to work with primary healthcare professionals and their societies to improve time to diagnosis. And patient groups really can be your ally in the support of these patients. So if you haven't got one, perhaps you could think of setting up one, and we will always help you to do that. And yeah, thank you very much. Next slide. I think it's just the end one. It's not. No. Oh, I remembered Petra. So coming soon, yes, the EMINA survey of unmet needs in MEN syndromes. It'll be on the EMINA website soon, or look out on social media. Any of your patient groups in your countries will be distributing this very, very soon. Thanks very much. Last slide, if you want.
Yeah, thank you very much, Jo. That was a great journey throughout the years you suffered from, and you and your family. So thanks for these insights. And indeed, the new survey is going to be launched in a few weeks, and we will manage this through all those newsletters and social media. And so we are happy to have new numbers for these things. Well, I think now it's the turn to the attendees. Are you ready for questions, maybe? So maybe a warm-up question. Which signs would you consider, Antje, as triggering signals for pediatricians to early diagnosis in MEN2B?
Chronic constipation, because it's present in 40% of the infants, and it's really difficult to treat. It's very and I tell all our gastroenterologists that if they think of morbus Hirschsprung, they also think of MEN2B, because that's very, very important that they know that there is another disease which has impact on the patient. And the others are not that frequent. Hip deformity, foot muscle hypotonia, but it's not specific. It's not such a specific sign. And tearless crying, but it's not in our medical records. I hope it's that parents know and tell the treating pediatrician, and he has to be aware. We always say, please be aware, but it's difficult. And I saw in Joe's slides that in Germany, 7 years it takes till diagnosis. It's sad for the patients.
Yes, it's always a long way, and people are not believing in your words, in your science. That's a problem as always. Frederic asked about Joe's wonderful comic books, that they are really great. Are there any possibilities to translate them in different language? Is there a problem of copyright? That's always the problem.
I know, I absolutely adore them. And yes, there is a problem. They're produced by a company that were in the UK, and I think now it's been taken over by a firm in the US. When we did it, we could only have hard copies, and we could only have a minimum of 50,000 of each. It was something ridiculous like that. So I've had more comics than we've got patients, I think, which is why I give them out quite regularly, because they're very interesting for medical students. Funnily enough, they quite like them. So yeah, it's unfortunate that I think anyone else of any other organization would have to go exactly through the same process as us, really. So yeah.
But do you think we could use the drawings, the pictures that are copyrighted also?
I'd have to check who owns the copyright, whether it's us or the company.
Okay.
Yeah.
The comics which are produced for different diseases, I don't think that they already have MEN types described. The British group, maybe we should check this, Frederic. I will send you the link. Maybe we can arrange that they start. I know that they do it for adrenal, for Edison and things like that, and how to use the Edison emergency kits. But maybe it's to raise awareness for our disease, for each of these MEN types. There are more questions about what I think is very important about the counseling service system. Joe, you described already. Are there regular questions? If so, which ones are used, or do they use open questions?
In the counselling service?
In the counselling, yes.
Yeah, it's they're all professional registered psychotherapists, and we kind of let them get on doing the thing that they do best. So I'm assuming maybe open questions, but yes, but they are specialised in rare diseases. They actually have their history based in a men's history, because the lead counsellor from Rare Minds actually started work with us, and she has experience of MEN in the family. So so she started working with us just a single counsellor basis, and then I think 2020 formed Rare Minds, and now there's a large group, and they've taken on a number of different rare diseases. So over the years they've gained that experience of talking with rare disease patients and carers, and even couples sometimes for relationship therapy, because you know, as a lot of us know, the relationships can be strained at the diagnosis time as well. So yes, we kind of let them do what they do best, and I try not to interfere too much. I pay the bills.
I think we should raise awareness for this kind of support within the Endo-ERN and the members, that there is a need, really a need for this, especially in these times. In every hospital, time is very short for all those discussions, and this helps the patients everywhere if they have someone who is in duty for this, all those questions. Well, looking to the clock, I think we must close now. Thank you all three. Thank you, Antje. Thank you, Joe. Thank you, Frederic, for your time. I think that was a very warm and interesting insight in all those questions. And maybe we should repeat this with another MEN type. We have enough of them. and to talk about this later in our next webinar. So for today, thank you everybody for your time, for your efforts, and for your numbers and slides. I wish you a nice evening. Take care, and hope to see you soon. Well, bye-bye, bye-bye, and thank you, Amy, for your help in the background.
Yes,
Thanks.
thank you.
Thank you.